I want you to imagine a really frustrating scenario.
Oh, I can probably guess where this is going.
Yeah, probably. So you are experiencing severe, relentless pain. I mean, it's just agonizing.
Right.
You go through this whole gauntlet of tests. You get ultrasounds, MRIs, blood work, all these structural exams.
And you're just waiting anxiously for some kind of answer.
Exactly. And then the doctor sits you down, looks at your perfectly pristine scans, and says, good news. There is absolutely nothing physically wrong with you.
Oh, wow. Which, honestly, is the most isolating thing you can hear when you're living in a reality of severe suffering.
Right. Because the pain is undeniably real.
Yeah, but it's suddenly become completely invisible to, modern medicine's most advanced imaging.
And that invisible pain is exactly the mission of our deep dive today.
It's such a crucial topic.
It really is. So we've got this stack of clinical guidelines, medical questionnaires like the DN4 and the LANS, and all this research on chronic pelvic pain.
And the goal here is to answer one really vital question.
Yes. What symptoms suggest your pain is neurological, like a wiring issue, rather than structural, which would be a hardware issue?
I love that analogy. Distinguishing between what we call nociceptive pain.
Which is the structural kind, right? Tissue damage.
Exactly. Structural pain. Distinguishing that from neuropathic pain, which is pain coming from the nerves themselves. It's one of the most vital yet misunderstood steps in modern medicine.
It seems like it would change everything about how you treat someone.
Oh, absolutely. If a doctor misidentifies the type of pain you have, you can spend years undergoing the wrong surgeries.
Just getting cut open for no reason?
Yeah, or taking the wrong medications entirely, all while the real underlying condition just continues to get worse.
So if an MRI or an ultrasound can't show us the difference between, a hardware problem and a software problem, how do doctors even start figuring this out?
Well, the detective work actually has to start with language. The clinician has to listen incredibly closely.
To the specific words you use?
Yes, the specific vocabulary. Because structural nociceptive pain has a very distinct dialect, so to speak.
Okay, what does structural pain sound like then?
It's typically described as dull or cramping or aching.
Sort of like a typical muscle soreness or a stomach ache?
Right. It's the language of tissue damage or mechanical stress. And it usually follows predictable physical patterns.
Okay, so like if someone has pelvic pain and it's cyclical.
Exactly. If it reliably gets worse right around your menstrual cycle, the probability leans heavily toward a structural issue driven by hormones.
Like endometriosis.
Endometriosis, yeah, or adenomyosis. Or if the pain shifts or temporarily goes away after you have a bowel movement,
then it's probably tied to the GI tract, like irritable bowel syndrome.
You've got it. It's altered by a bodily function. Or even if a doctor presses on a specific muscle trigger point, and that reproduces the exact aching you feel.
That'd be myofascial pain, right?
Right. All of those are tied entirely to the physical mechanics of the body.
So treating structural pain is basically like having a broken pipe or a cracked foundation in your house.
Yeah, exactly.
You find the leak, you patch the drywall, or you fix the floorboard that creaks when you step on it.
But neuropathic pain is a totally different beast. It comes from a lesion or a dysfunction in the somatosensory nervous system itself.
So the actual tissues and organs could be perfectly fine.
Perfectly healthy. But the sensory pathway, the nerve tasked with reporting on those tissues, is malfunctioning.
Wow. So how does the vocabulary change for nerve pain?
Patients completely stop using words like cramping. Instead, they start describing severe burning.
Burning, okay.
Or sudden violent electric shocks. The descriptors become incredibly vivid, honestly. Intense tingling, pins and needles.
Well, I've heard people describe it as a really intense, painful, cold sensation, too.
Yes. That painful cold is a massive hallmark of a nerve misfiring.
So if structural pain is the broken pipe, neuropathic pain is more like a faulty electrical wire sparking behind the drywall.
That is the perfect way to visualize it. From the outside, the wall looks totally pristine.
The paint is perfect.
Right, but inside, the electrical currents are arsing and misfiring, creating this localized hazard.
But wait, if you can't easily see these sparks on an X-ray because an X-ray just looks at the drywall, how does a doctor actually prove the wire is faulty?
That is where things get really interesting. To find that spark, doctors actually rely on some of the most fascinating low-tech clinical tools in medicine.
Low-tech? Like what?
Well, they use these highly validated clinical questionnaires, specifically the DN4 and the LANS.
The LANS, what does that stand for?
It's the Leeds assessment of neuropathic symptoms and signs. And these aren't your standard, rate your pain from 1 to 10
Right,
forms.
because everyone just says an 8 anyway.
Exactly. These questionnaires hunt for bizarre, highly specific physical clues. For instance, the LANS asks if the skin in the painful area looks mottled.
Wait, mottled? Or like abnormally red?
Yes, compared to the normal skin around it.
I found that detail so strange in the source material. You wouldn't intuitively associate a nerve issue with skin discoloration.
No, you wouldn't. But nerves do more than just send sensory data to the brain. They also regulate autonomic functions like blood flow to the capillaries in your skin.
Oh, so an irritated nerve can actually trigger localized redness in that specific area.
Precisely. The LANS also zeroes in on the timing of the pain. It checks if you get sudden bursts of pain for absolutely no apparent reason.
Like when you're just sitting completely still.
Yeah, zero movement, no physical trigger at all, just a spontaneous electric shock.
Wow. And there are specific scoring thresholds for these, right?
Yes, so the DN4 has 10 items, and a score of just 4 out of 10 strongly suggests nerve pain.
And the LANS?
The Lances is scored out of 24, and anything 12 or over means the pain is predominantly driven by nerve dysfunction.
Okay, so beyond asking questions, do they do a physical exam?
They have to. They have to test the peripheral wires directly. And this brings up the cardinal symptoms of nerve damage: allodynia and hyperalgesia.
Okay, let's break this down. Hyperalgesia is an exaggerated response to something mildly painful.
Right. Correct. Like a light pinch that should just be a tiny annoyance, but your brain registers it as agonizing trauma.
And allodynia is even weirder. That's pain caused by something that shouldn't hurt at all.
Exactly, like the light brush of cotton clothing against your skin, or just a gentle stroke of a finger.
Why does that happen?
Well, in a healthy system, a beta nerve fibers handle light touch and C fibers handle pain. But in a neuropathic state, there's a cross-wiring effect in the spinal cord.
So the light touch signals accidentally trigger the pain pathways.
You've got it. And this cross-wiring is why one of the single best diagnostic tools for nerve pain is just a simple wooden cotton swab.
Not $1 million MRI machine. A cotton swab.
A cotton swab. A doctor lightly brushes it against the skin, and if that harmless touch provokes a sharp burning sensation,
They found an area of allodynia.
they've mapped the faulty wire.
But I noticed a huge contradiction when I was reading about the DN4 criteria.
Oh, the paradox.
Yeah. It asks the doctor to check for allodynia, that hypersensitivity. But it also asks if you have hypoesthesia in the exact same area.
Hypoesthesia meaning numbness or a loss of sensation to a pinprick.
Right. How is that biologically possible? How can an area be intensely painful but completely numb to the touch at the exact same time?
It sounds impossible, but it's a very real clinical state known as anesthesia dolorosa.
Painful numbness.
Basically, when a nerve is severely damaged or partially severed, it loses the ability to transmit normal touch sensations, so it feels numb to you.
Okay, makes sense so far.
But the damaged nerve stump becomes highly unstable. It starts firing off chaotic, spontaneous pain signals to the central nervous system.
So your brain is basically getting a contradictory message.
Yeah.
I can't feel this part of my body, but it is currently in absolute agony.
Exactly. It's a terrifying experience for the patient.
To really make this concrete, let's look at what the sources call the ultimate wiring case study.
Oh, the pudendal nerve.
Yes, the pudendal nerve.
Yeah.
Because its positional symptoms perfectly reveal neurological causes.
It is notorious among pain specialists. It's one of the most complex nerves in the human body.
Where exactly is it?
It travels a really winding, tortuous path from the sacrum down through these narrow anatomical tunnels in the pelvis. It controls sensory, motor, and autonomic functions for the pelvic floor, genitals, and anus.
And because it weaves through such tight canals, it's super vulnerable to mechanical irritation, right?
Highly vulnerable, prolonged sitting, intense cycling.
Trauma, or even surgical scars.
Yes, all of those can compress or inflame the nerve, leading to pudendal neuralgia or PN.
And for a long time, figuring out if someone had PN was just guesswork. Until the Nantes criteria.
Right, the universally ratified diagnostic criteria for PN. And the Nantes criteria focuses heavily on positional clues.
The biggest one being that the severe burning or electric pain gets significantly worse when you sit down.
Yes, sitting is the defining trigger, but the relief is just as diagnostic.
Meaning it improves when you stand up or lie down flat.
Exactly. And crucially, this is a huge detail. The pain does not wake the patient up from sleep.
Wait, really? If the pain is so severe you can't even sit at a desk, you'd think it would ruin your sleep.
You would. But this nerve pain is dictated by mechanical tension. When you sit down, you put direct physical pressure on the ligaments that compress the nerve.
Oh, so when you lie down, the tension goes slack.
Right. The hose is unkinked. Plus, when you hit deep sleep, your central nervous system actively downregulates sensory input.
So if someone is actually waking up screaming in pain in the middle of the night,
Then the doctor should immediately look away from pudendal neuralgia. Night pain usually points to an aggressive structural pathology, like a tumor or a severe infection.
that is such a clear distinction. But doctors still get it wrong all the time, don't they?
All the time, because differentiating nerve pain from structural issues takes immense clinical vigilance.
Like a patient with burning pelvic pain and a frequent urge to pee is constantly misdiagnosed with a persistent UTI.
Or a chronic prostate issue in men. But
Yeah.
if you apply the positional logic we just talked about.
Right. A UTI doesn't magically stop hurting just because you stood up from a chair.
Exactly. Another huge red flag for the pudendal nerve is the foreign body sensation.
Feeling like you're perpetually sitting on a golf ball.
Yes, even though exams and imaging confirm there is absolutely nothing there.
That's the nerve's autonomic fibers misfiring again.
Yep. Sending a false signal of severe fullness or pressure to the brain, which the brain interprets as a physical mass.
I have a question about the sitting thing, though. Is this pain literally just mechanical? Like stepping on a garden hose and stopping the flow?
Well, we have to draw a line between general pudendal neuralgia, which is a functional symptom, and actual pudendal nerve entrapment, or PNE.
Okay, what's the difference?
You can have neuralgia simply because your pelvic floor muscles are locked in a chronic spasm, and those tight muscles irritate the nerve.
So physical therapy could help relax the muscles and fix that.
Exactly. But pudendal nerve entrapment means the nerve is literally physically trapped between ligaments. And in that case, you might actually need a surgical release to free it.
Okay, but this brings us to what I found to be the most complex part of our deep dive today. Let's say the surgeon goes in and frees the entrapped nerve,
Right.
or they perfectly remove the ovarian cyst. The structural insult is fixed, the tissue heals, but the burning electric pain doesn't stop.
It's a dark reality in modern pain science.
Why does the alarm system keep going off when the threat is gone?
Because of a phenomenon called central sensitization.
Central sensitization.
Yes, neuropathic pain might start with a peripheral lesion like that faulty wire in the pelvis, but if that wire sends severe pain signals to the spinal cord for months or years,
The constant barrage actually alters the central nervous system.
it fundamentally rewrites the software processing the signals. Deep in the spinal cord, these specific glial cells become hyperactivated.
And they change how the neurons communicate.
Literally. Yes. Receptors get stuck in an open position. The central nervous system essentially turns up the volume dial on all incoming sensory traffic and loses the ability to turn it back down.
It's like, okay, the original fire in the kitchen has been put out. The flames are gone, but the smoke detector is broken and keeps blaring anyway.
That's exactly it.
And at that point, you don't need a firefighter anymore. You need an electrician to reset the alarm.
Right. Because the nature of the pain completely changes. It stops being highly localized to the original injury.
It becomes diffuse. Yes.
Diffuse, often bilateral spreading across both sides of the pelvis or down the legs, and the reactions become totally out of proportion.
So, like, you could sit in a chair for 15 minutes, just a normal everyday thing, and it triggers a pain flare so bad you have to lie down for 3 hours.
Yes. When a clinician sees that kind of extreme, disproportionate reaction to a minor stimulus, it's a glaring indicator that the central alarm system is stuck.
Which explains why doing another surgery to fix the pain is a terrible idea.
It's disastrous. Ripping out the kitchen cabinets won't fix a blaring smoke detector. More surgery just adds massive new trauma to a nervous system that's already hyperreactive.
And standard painkillers like NSAIDs or opioids don't work either, do they?
Rarely. They don't address the altered synaptic processing in the spinal cord. You have to shift away from structural fixes and use centrally acting neuromodulators.
Like anti-seizure medications or antidepressants?
Exactly. Things like gabapentin, pregabalin, or amitriptyline.
Which I'm sure confuses patients. Why am I getting an antidepressant for pelvic pain?
Right. They aren't prescribed because the doctor thinks you're depressed. They're used off-label to act as chemical gatekeepers. They work work directly on the spinal cord and brain to force that stuck volume dial back down.
It's just a massive paradigm shift. You have to stop searching for the broken bone on the X-ray and start treating the invisible processors in the central nervous system.
It really reframes everything. It's why those low-tech tools, the questionnaires, the cotton swab, the careful listening to vocabulary are infinitely more powerful than a multi-million-dollar MRI for chronic pain.
The imaging evaluates the hardware, but the clinical exam interrogates the software.
Beautifully said.
So to summarize all this for you listening, distinguishing between structural and neurological pain comes down to the body's clues. Structural pain speaks the mechanical language of a broken pipe dull, cyclic, tied to movement.
Right.
While neurological pain brings this bizarre dialect of electric shocks, painful cold, and mottled skin. It's the allodynia from a cotton swab, the painful numbness, and the highly specific positional triggers, like the sitting pain of pudendal neuralgia.
And when you look closely at central sensitization, it leaves you with a truly profound realization about neurobiology.
Yeah, the fact that chronic, unmanaged pain can literally alter the physical structure of your central nervous system.
The brain physically remodels its own architecture in response to persistent suffering.
Which leaves us with this final thought to mull over. If our brains can fundamentally alter how they process pain, basically creating a severe physical reality long after a bodily wound is healed, how much of what we experience as physical illness is actually shaped by the silent, invisible neuroplasticity of our own minds?
It requires us to completely reevaluate how we look at a normal X-ray. The pain might be totally invisible to the machine, but it is deeply neurologically real.
Definitely something to remember the next time you or someone you love is dismissively told their pain is all in their head. Because in a way it is, but as a very real rewiring of the brain itself.